Okay, thank you for inviting me today. I guess, I mean, I want to share just my experiences a little bit of working with Dr. Kidd in the Barts in London, and kind of how we've come to have this presentation with the Sarcoidosis UK Society. I'm having some problems transitioning slides. There we go. So a little bit about me. I don't work specifically with people with neurosarcoidosis or sarcoidosis at all. So I'm going to kind of pull on my general experiences of working with people who live with autoimmune inflammatory diseases, and I'm expecting and hoping that there'll be overlap here with neurosarcoidosis. And I'm hoping I'm going to blend some of the psychological theory models. I won't do much psychobabble because I realise how dull that can be, and I'll try to keep it as real as I can. But it is my worldview and my experiences. So, you know, if people have other kind of lived experiences and views on these things as well, and I accept that. I think that's a thing that we should share and discuss, because I think that's how we come to a greater understanding. Okay, I guess the first stance I have, and it is a golden rule in psychology, in fact really should be in all mental health care, and I think some of the questions that have come up do reflect some of this. You know, is the idea that before we think about people's psychological well-being, I think is a presentation a function of their physical state, and or is it a function of their social and environmental context, so how they're living their lives, and the limitations are placed on them. And I have to say, in my work now, it's been really quite rare that I've come across people who present purely with the psychological concerns. This is very much linked with their physicality, physical state, and how they find in their lives at that time. And I hope I can kind of bring some of that to the discussion today. So I'm going to look at sort of three parts. The first is, and it's difficult for me, I wasn't sure how to do this. There's always kind of ways to, you know, do I go from the outside in or the inside out? Do we start with very specific things around, you know, immune conditions or sarcoidosis, or do I start in the broader theme? And I think I've gone for the broader theme about the experience of living with inflammatory diseases. First of all, and then honing more into some of the psychological aspects of these particular conditions. And then we'll look at the end at some ways of helping. And I've tried to keep these also, I think, practical and ways for people to engage in some self-help, as well as maybe access things like therapy. Now, okay. So let's start for sort of 10 minutes or so, or we'll see how it goes, on the kind of living with immune disorders. Now look, I'm starting at the way beginning here, you know, and why am I starting at the way beginning about our early relationships as children and people around us? But I guess I'm doing that because I want to make sure that everyone comes with their own unique personalities and take on the world. And I think we have to understand that when we think about working with disease and autoimmune conditions and all other conditions, that people bring their life with them and their personality with them. And that flavours very much, I think, how people respond to and cope with the diseases and the adversity that they have to face. So without any further apology, I will look at a little bit of this stuff. This is like a one slide on psychoanalysis, if you like, or attachment theory. So we have these early relationships that become really the blueprint for us and how we relate to the world around us, to other people, and also for how we relate to ourselves and the inner world. And I think that's really important in terms of how we then approach self-care and advocating for self, and how we approach healthcare systems and what we expect from them. Additionally, I like to look briefly at this system as well, which is Gilbert's motivational systems. Now, I like this. It's a very simple idea. It's based in evolutionary psychology, and it's really about three different systems of motivation. One is a drive system that's linked to attaining goals, leads towards, new resources. It's generally dopamine mediated. It's about pursuing, it's very focused, it's achieving things, and it's balanced by a threat system, which is adrenaline and cortisol based, which is about anxiety and anger and avoidance of things, and a soothing system, which is really really related to nurturing, feeling safe, feeling loved and cared for. Now, these systems are shaped by our early life experiences and growing up, and they continue to be shaped throughout our lives, which I think is the kind of maybe the hopeful aspect of this. Some of the maybe psychoanalytic and attachment models that are a little bit feel a little bit less hopeful in their shaping, but our experiences are continually shaped by the way we relate to ourselves are continually shaped by these experiences, and as you can see. So, as we grow up and through our lives, we have different experiences of nurturing, of caring, of belonging, but also the experiences of competitiveness, of goal attaining, of career progression, of gaining things, and also unfortunately experiences of fear and exclusion. And they all come to shape us. And in our society, generally, particularly in this country and typically Western societies, we're kind of really culturally conditioned into a kind of drive and a threat system, which tends to be overdeveloped. Systems of driving, achieving and pursuing careers and being competitive, and also the fear of things going wrong. And these systems are often quite closely related. And the system that tends to be ignored or underdeveloped is the system of soothing, of being looked after, of being cared for. I think, when we think about psychological therapies and well-being practices, this is the area they're looking at develop. And there's a whole massive industry of well-being out there, and they're really about trying to get us to look after ourselves a bit more, and to balance out some of the other kind of slightly overdeveloped drive and threat systems that we experience. So there's maybe some kind of imbalance in our society that psychology and well-being practices kind of seek to balance out. But I think that is a backdrop for all of us, and we should kind of really think about that when we think about our relationship to self and relationship to health and relationship to helping others. Okay, so let's have a look at about this medical journey when you have an autoimmune or inflammatory condition, and making sense of the experiences of some of these symptoms. When people first experience symptoms, there's that kind of decision-making process that goes on for us, which is the knowing when to seek help. When do we go to the doctor? When do we go to hospital? When do we? At what point do we do this? And we have to. This isn't something that occurs naturally. We have to think about this. At what point am I ill enough to be seen? And it's an important skill. And I think as we go through this sort of cycle with autoimmune conditions and this medical journey, it gets eroded, and people's sense of being able to tell when they're ill gets seriously, I think, distorted through their experiences. And you see this cycle developing, and it's of going to hospitals, of having a range of symptoms. Medics and doctors and healthcare professionals really maybe realizing something wrong, not really sure what's going on, not able to pinpoint the causes of things, and then it can lead to a whole load of various appointments and sending off to different specialists and hopes for diagnosis and treatments and hopefully cures. And this cycle, I think, can be really quite toxic, particularly if it continues for a long period of time. And unfortunately, with these conditions, my general experience is that people go around this cycle, round and round, many times, sometimes for years. And I think that the gap between symptom, or the delay between symptom and diagnosis, the longer that delay is, the more kind of toxic this journey can become for people, leading to personal despair, feelings of exclusion from others, and being very separate from people. And frankly, people can often feel that they're caught up in their own kind of personal madness. The repeated hopes of appointments to see new consultants with a potential diagnosis, only to be told that it's not this condition or not that condition, can really leave people in a state of despair. And often people will tell me in the clinic that I work in that when they're not diagnosed, that it's often very devastating for them. They're thrown back into the sea, as it were, without a life raft or a life belt to help them, and feel like they're drowning again. And these unfortunately can go on for years for people. Now, I'm particularly looking at this, and I think, I wonder, this is a new slide I've added to this kind of talk. I've done this talk to a different number of groups, and I see this all the time. And I think it's really important to kind of emphasize it with people, and to get people to think about it, because often people don't recognize it in themselves. Now, this is really the idea of this cycle of journey to diagnosis, and the idea of medical trauma. And of course, it doesn't just occur at up to diagnosis. It goes on beyond diagnosis, and when we're seeking help for arising and complex issues that come up. Now, the literature is quite clear around, that medical trauma can arise from major medical events, but we also see that they can arise from repeated, multiple, minor, so-called minor healthcare events. When people are unwell and have got to repeatedly go to hospitals or doctors. And in combination with that, it can also arise from repeated difficult consultations. And I think this is a real shame, and a real area that as healthcare professionals we really need to be thinking about. And it arises from just lack of knowledge of condition that people have, the feeling and the actual not being believed, or having healthcare concerns minimised or dismissed as not important, leads to a real sense potentially of despair, distress, of being rejected or abandoned by healthcare services. Now, I'm going to come back to this a little bit at the very end. I'm going to look at healthcare consultations in particular, and just have some thoughts with you about maybe what you can do, or some understanding of what goes on in the healthcare consultation. I think is, really, really important for people to understand in order to try and get the best out of the healthcare professionals. So for the lucky ones, if you like, sometimes after years, they might finally get a diagnosis. They land in a specialist clinic. They might see some specialists, meet other people who have the same condition, and they're like, wow, that's amazing. And they can also be very happy at that and relieved that they've got a diagnosis to hang on to. And as I said, people who come in for a diagnosis and are told that they don't have a condition, or even worse, they've previously been told they've had the diagnosis, and then they come to a specialist clinic and the diagnosis is taken away from them. It's devastating often for them, and they fall, as I said, back into that kind of feelings of personal madness. But great, so people have often quite happy at being diagnosed, even though they may realise that this is quite a difficult diagnosis and there's help and treatment. But at some point there may well be a realisation that there's not a cure, and that's particularly obviously for the more kind of chronic conditions, or the aspects of diseases that can be more chronic rather than kind of that are more short-lived. And it's often at this point that people really have to start reevaluating their lives and what this might mean for them. And I guess we akin it to a kind of grief process. And, you know, there's a simple equation I think I see in the clinic is you know, the bigger the gap for the hoped for life versus the actual life that someone's leading, leads to greater distress. And particularly when they see those around them moving on with their lives in ways that they feel left behind, or ways that they feel their life is shifting and changing in ways that they hadn't expected or wanted. So people will go through, usually go through some kind of grief process. Now I've put up Kubler-Ross's 5-stage grief process. It's a little bit of a clunky model, but it's one that people are often very familiar with. And I would kind of maybe make some adaptations to it, in the sense that I certainly see that people, yeah, they do go through these stages, but actually they often go through them repeatedly. Throughout their lives even, and this is kind of the end stage that Kubler-Ross says, which is one of acceptance. I'm not sure is realistic in many ways, and I kind of prefer to think of the idea of acceptability rather than acceptance. Acceptability is more of a fluid term, more dynamic. It means that sometimes living with a condition is more acceptable, and other times, frankly, it's just not. And that's the last thing we want to be having, is having to live with this. And people can go back through the various stages of this kind of process for a long time, and move through it continually, I think, particularly when major life events happen. So that's a little bit of that process. It can go on for a long time. It can go on for a long time. And I just maybe put some quotes, as you may have noticed, there's some quotes from people I've worked with, and this is more like the section's been a bit more of some comments that people have made with me, and I kind of used to illustrate. So, you know, the idea of adjusting to living with symptoms, the idea that you know, people have to think on a daily basis, where am I now? What's it like now for my health? Have I got symptoms today? How bad are they today? Can I do things today? Can I do the things that I had planned to do today? So the symptoms can become all-encompassing at times for people, and always present. And even when people are in remission and maybe don't have symptoms, there's always the anticipation or the worry, well, yes, okay, I have no symptoms just now, but when were they going to come back? So people can be really quite preoccupied with them. I think the idea of kind of learning to go slower, we call it pacing in psychobabble, and I'm sure a lot of you have heard this, because I'm sure a lot of you will have been through things like, well, you may or may not have been through chronic fatigue type services and things. You may have done, and you'll get a lot of talk about pacing and things in these kind of clinics, which is easier said than done, because actually people don't want to accept tough to pace their life. It's very difficult to learn to go slower, but of course there's that balance in people's life about doing too much and triggering off relapse symptoms. So even when you're trying to manage this, it's always in mind about managing the symptoms that might come. And slightly kind of that wider aspects of us, how we relate to other people in the world around us. You know, people repeatedly get locked into painting themselves in the corner of never planning to go out, and kind of losing that spontaneity of life that is so important for us, and the fear and the experiences of having to cancel or come home early, or feel that they're letting people down because they're unable to make it. They've had a flare, or they're feeling fatigued. And noticing over the years as friendships and acquaintances start to drop away, in the increased isolation that can bring for them, and a sense of sadness about their lives. And if they're very lucky, and actually most people are, they will have a few friends who will accept them and understand, and these people are like gems in your life, and you should hang on to them for sure. And in the idea of work, you know, Desmond kind of touched a little bit on the issues around work and getting people back into work if that's what's helpful for them. But you know, work can be, it's hugely important for people's lives in terms of their identity, never mind the kind of material things and finances that it can bring, but also giving purpose and meaning. And the idea of work ethic is strongly imbued in our culture. And the experience of people who, in terms of trying to balance up a work life, how do they explain to colleagues, how do they explain to their managers, their bosses, or how they run a business when they have flaring and periods of time when they're unable to work. So the relapsing nature of these conditions and the persistent nature of these conditions really disrupts people's ability to engage in a working life productively. Some people do give their all to work and their life's really imbalanced, so they give all their energy into work and then they've no energy left for their families. And then also, you know, as you see in this kind of quote from this person, that actually being unable to work and having a disease that appears invisible or hidden to people's eyes, and the being held in the gaze or the critical gaze of other people, or at least the perception of it, and the effect it has on people and their sense of who they are. And of course, one of the ways people cope with this, and it's such a remarkable thing, that people mask themselves. They keep things to themselves. They don't tell people. They stop talking about their symptoms. They stop talking about how ill they feel because people don't generally understand it very well. Yeah, for some people, this kind of driving forward, people who keep it to themselves and always, if they're ill, they push themselves that extra bit. Some people say that's been a friend to me in my life because it's made me get up and get on and do things. However, it's also been an enemy in that it's caused lots of frequent relapsing and people go into what we call boom and bust. So they over push themselves and then they have major relapses and they fall flat, only to pick themselves up when they recover and do the same thing over and over again. And the other thing that masking does, which, you know, it's important because we all have our social face and we all want to present ourselves in a good way to the world, and I think that is important, and it's important for self-esteem and self-image. But the flip side to it is that everybody thinks you look okay, and they've got no idea that it's taken hours or to try to get ready in order to put this face on to look out into the world and to go out into the world. So there's often a sense of isolation, exclusion, and a further sense of not being understood from this. But yeah, the balance is a difficult one to achieve, I think, and I think most people don't achieve it very well. And then over time, there's often a real change sense of who people are. You know, it might be gendered, the sense of themselves as a woman or as a man, the sense of who they are in the world, their roles and responsibilities in the world, the guilt that's sometimes attached to feeling that their loved ones are having to help them, and their relationship to that, needing help from others, and often senses of guilt and shame that, you know, that can be quite painful and difficult for people to discuss and think about, and how they move on. And, you know, this is the common thing that I see in most people. is they blame themselves often and think, what is it about them that's not capable, that's not working? Why am I the one who's inadequate here? Why can't I push through? Why can't I feel better? Why can't I do things better? And you know, as I said at the kind of strap line at the beginning was, there's actually nothing wrong with people. They're ordinary people. It's what's happening to them that's extraordinary. It's the living with an inflammatory disease, one that's not well understood, and it's the social context and the culture that we live in that people don't see this, and our culture generally, and psychology is really bad. I think psychology is part of this. Is that we promote this idea that change is always within the individual, and I think that's not true. You know, at this point, for this kind of general experience of living with autoimmune conditions, now the work that I would aim to kind of support people in is thinking about a values-based living, moving towards living bits of the life they want in ways that they want. It might not look like what they'd hoped it would look like, but they can still have it in different ways. And really thinking about people's values in life and using that as a basis, as a foundation or a scaffold to then think about, okay, how can I rebuild my life and build my life in a way that's meaningful for me, and rebuilding and reshaping that relationship with themselves. So, living with, so just to sum up this section, really, living with autoimmune disease, we grow up as children and young people and as adults, and we're influenced by all those around us, and these influences shape us in how we see ourselves, and that very common, that often toxic journey from symptom to diagnosis and living without a diagnosis, and sometimes the very difficult experiences that people have when they seek help in this medical journey. And then beyond that, there's the meaning of diagnosis and of a changed life, the impact it has on their ability to live a life that they had lived, and impact on how they see themselves in the world. And then how we can kind of start to rebuild and help people make room a little bit for the disease that they're living with, and rebuilding their life in a values-based way. So I think this is really common experience really across the board for people with autoinflammatory and autoimmune conditions, and other conditions, of course. So I think that's the backdrop, if you like, and I think we have to always be contextualized within that, and it's so important to do that. We can't just come in with symptoms, and of course when we engage with medical or healthcare professionals around our mental health issues or physical health issues or our coping issues or whatever they are, there can be a tendency to be a little bit reductionist and just look at symptoms, and I don't think it's helpful, particularly when we look at psychological aspects of it. So with that in mind, as a backdrop of living a life with an autoimmune condition, let's drill more into the kind of mind-body relationship. And I'm kind of regretting calling it the mind-body relationship, because that can suggest there's some sort of relationship or some sort of difference, or even, and I don't believe that there is. So the first aspect we're going to look at really is the aspects of flaring, or the immune system's inflammatory response, and the kind of common psychological and behavioral changes we see in people across all these autoimmune inflammatory conditions that are common to them. Really, there are a whole lot of changes that are adaptive, and they're a non-response to infection disease. They're part of the immune system, and they're really there to help us get through infections. They're generally caused by the cytokines released by the innate immune system that's there to that causes an inflammatory response, and it's called sickness behavior. Now, sickness behavior is I alluded to, it's an evolved, it's cross-species. You see it in all animals pretty much. And it's a lot of behavioral changes that develop in people who are unwell, or individuals or organisms that are unwell during the course of infection. It's a motivational state that reorganizes the priorities of the organism or the individual to cope with infection. And you know, it's a lot of research is now looking at the kind of crossover between this and the understanding of things like clinical depression. And I think as we go through this, we'll see that you know, what is this relationship between what seems to be depression and what seems to be physical things and what seems to be mental things. I don't think it's particularly confusing, but I can see why people who maybe and professionals who've not really thought about the connections here might get them mixed up. And I think there's been a lot of questions around this. So, you know, behavioral illness responses. So we get malaise, that kind of general sense of something wrong, tiredness, excessive sleep, heightened pain experience, the loss of appetite that goes with this, reduction in self-care and grooming, loss of enjoyment, lack of motivation, so lack of motivation to do things, cognitive issues like lack of ability to concentrate, and we see anxiety. And you see it across a whole range of conditions, and these are just a few examples, like multiple sclerosis, HIV, traumatic brain injury, cancer, chronic fatigue, fibromyalgia, rheumatoid arthritis, lupus, depression, a whole lot of them, and sarcoidosis is one of them. So how does this kind of manifest in people? Well, you get flat moods, people might get irritability. There may be kind of thought processes that are kind of really lack of enjoyment and sometimes hopelessness. What you tend not to get, and I think this is where I would differentiate it from clinical depression, not always, but mostly you don't get the kind of nihilistic thinking that goes with a clinical depression. So that tends to be absent, as does suicidality tends to be absent as well. However, that's not the case for everyone. Some people who do get, I see mood changes in response to, or a flattening of mood in response to a flaring, do get activation of some more depressive and suicidal thoughts. But that's generally people who've maybe got a history of clinical depression. They may get these thoughts reactivated. So there's a relationship between them, I would say. And of course, those kind of behaviours, the lack of motivation to do things, withdrawing socially, less self-caring, and coming from the outside, if someone didn't realise you were flaring, they would probably think you were depressed, because it would look like that kind of, there's sort of what we call negative symptoms of depression, the kind of the flattening, the withdrawal, the slowness, the not wanting to do things. So it could quite easily be confused as a clinical depression. You get cognitive problems, colloquially known as brain fog, and I'm sure a lot of you have come across brain fog as an idea, and I'm sure you'll experience it as well. It's very, very common. It's kind of mild cognitive impairment. People have problems with particularly concentration, I would say, and memory. So usually for things they've just done, so not so much memory about who they are and their personal history, but they might not recall things like words and names and things. So it could be problematic. But particularly the hippocampal function can be affected, and that's really where you're laying down new memories and you're kind of recalling things, and that can be a bit impaired in this brain fog. And it could be quite, the brain fog can be quite substantial and quite debilitating. And so very typical things people will talk about is, they're in a conversation and they'll lose the thread of the conversation halfway through. They may be doing something in the kitchen and then, I don't know, the telephone rings, they pick up the phone, answer the call, and then they forget that what they were doing in the kitchen. So they've left the iron on, or they've left something in the oven, and so it interferes with their everyday functioning. Or they go to the shops and they've got 5 things they're going to buy and they can only remember one of them. So very typical kind of problems people have, but it can be quite debilitating and quite worrying for people. And then this kind of pain perception, so you'll get the flare-related joint pains that accompany that, and sometimes we'll get kind of body pains and body aches. But importantly, I'd say from this, there's activation of the brain's pain network. So you will get what we call change in pain perception. So a reduced threshold and tolerance. So which means there'll be a reduction in the things that will cause pain. There'll be a reduction in your sense of when things are and are not pain. So things that may have previously not been seen as painful will become more painful, or be seen as painful. So that threshold is crossing over into pain, it changes. And the tolerance as well. So the tolerance about what is really painful also drops. So things that maybe when you weren't in flaring wouldn't really cause much pain will cause a lot more difficulty and feel more painful. So you'll get this worsening of maybe pre-existing pains. So if someone has a comorbid pain, like they have a back pain or back injury, that may become more aggravated or feel more aggravated. And people even report old injury sites kind of becoming painful again. So this whole kind of pain network kind of becomes highly sensitized. And of course, as you all experience, the fatigue, and that being combined with lack of motivation or lack of enjoyment can really can look a bit like depression. But the fatigue, as we know, is very profound, and it's not like tiredness. And unfortunately, the word fatigue is much maligned socially. Fatigue, I think, has a stigmatized history for sure. And one that's minimized and not understood by people generally. And this is, I think, where people feel very misunderstood when they talk about fatigue to family, friends, or other people out there who really don't understand the difference between tiredness and fatigue, where there's this profound lack of refreshment, despite excessive sleeping or resting. There's no sense of refreshment and no sense of recovery. So these are all really aspects of the immune system flaring. That is very common, and people often struggle to make the link between these flares and relapses and changes in their psychological state. And they often go around questioning, what's wrong with me? Why do I feel like this? Why am I not strong enough to overcome this? Why am I feeling depressed? Many people will think that they're feeling depressed when in fact it's a flare. But I think understanding that can be very helpful for them. Understanding that there's actually nothing wrong with you. I mean, nothing wrong with you as an individual, and that you're feeling like this because that's how you should feel like that, because you're in a state of relapse. That's what I kind of call flare-related or inflammatory-related psychological and behavioural changes that you see in everyone. Coupled with this, now we've talked a bit already about having to live your life and change your life and adapt your life and adjust hugely to the process of living with these conditions. And of course, people can get what I'd call secondary depression, a clinical depression on top of this. There can be hopelessness for themselves in the future. And because they see that their relationships and their hopes and their dreams and their work life has changed hugely, it can push people into depression for sure. So you can get that overlaid on top of depression and mood changes that arise from the inflammation. You'll get secondary anxiety as well. Often with chronic hypervigilance, people might always be on edge. They're worrying about the future, so that may appear as well. And then secondary pain might come. So you've got pain associated with the disease process, but then we know that guarding behaviour occurs reflexively. So when we have aches and pains, our body will automatically tense and guard itself away from that pain, which then causes either referred pain or puts pressure on other parts of the body, and then can cause other secondary pains and development of mechanical pain on top. And then you can get a secondary fatigue, which would be a combination of kind of like physical deconditioning. So people being unable to exercise, unable to do things, and developing fatigue based around or tiredness based around physical deconditioning. And I think a lot of the chronic fatigue kind of models buy into that a little bit, the physical deconditioning aspect of it. Where some of their ideas might be helpful, but I think some of their ideas around fatigue management with the inflammatory form of fatigue, I think, is not very helpful. Okay, now, and then finally, I'm going to look at time checking this. Okay, we're 10 to 4. Okay, so now I don't work in sarcoidosis, so this is up for open discussion now. So I've kind of had a look at the literature a little bit, and I've had some thoughts really about it. So really, just to summarise, we've looked at kind of who you are and how you've gone through this process of changing your life, and also the things that accompany that. Socially and personally, as well as the psychological and behavioural changes that can occur due to the inflammatory response in the body. Now, and the response and our experience of these things. Now, sarcoidosis, specifically, I looked at really a few things. I did think the kind of lung function was quite interesting from the idea of fatigue, but also potentially for like panic-like symptoms, like triggering a physiological panic-like symptom. And I was wondering a bit, and maybe Desmond could help me here, or maybe you could all help me here with this one, about kind of like oxygen saturation and oxygen blood levels and things, because we know that at certain points, there are certain trigger points physiologically where you will go into a panic. The body will go into a physiological state of anxiety when it's over-oxygenated. And then cardiac aspects of sarcoidosis, certainly arrhythmias seem to occur, and of course arrhythmias will also be associated with potentially triggering panic and anxiety type symptoms in people as a kind of physiological feedback. And I guess lung function would as well, if someone was exerting and having difficulty breathing, would maybe trigger off a panic symptom as well. And of course, cardiac and lung are going to contribute to feelings of fatigue. And I'm aware that the kind of skin lesions and some scarring can occur in sarcoidosis. I don't know the extent of it, but that then raised issues for me about ideas around body image concerns and people's sense of their bodies. And I wondered a bit about that, and maybe that's something that we can talk about a bit more as a group. And then I think Desmond's covered a lot of this, and I thought it was really interesting to hear things he was saying about this. And I'm aware that that the hallucinations can occur in neuropsychosis, and I was wondering if that was really, again, a lot of this is to do with either the inflammation going on in the brain and or the kind of experience of nodules and granulomas and things and in different areas of the brain. And I was quite interested to have a think about that with Desmond. And because people experience mood swings because of I guess the inflammation in these different parts of the brain. And it seems to go from kind of real swings of depression to euphoria. You get aggressive irritability and some kind of personality type changes. The dementia that seems to come, that I've read about anyway, and I guess it would be also interesting to think about with Desmond. It seems to be more reversible largely, but I'm not fully sure about that. And then this idea of kind of memory and cognition. Now, look, there's very little in terms of cognitive studies in neuropsychosis. There's not a big literature base out there, and aspects of it seem to be a little bit equivocal. There was one study that looked at kind of cognitive failure, comparing sarcoidosis patients with sarcoidosis patients, and you can see that, yeah, okay, it seems to be much more common in people with neurosarcoidosis. However, it's also very common in people with sarcoidosis without brain involvement. So, you know, the question for me is this really related to the inflammatory process? Is this brain fog that's going on versus actually is it brain damage that's going on, and people's cognition being impaired because of damage caused by the inflammation and the kind of nodules? And I guess that's something we should think about, maybe have a chat with Desmond around this. Certainly that study did seem to find a kind of a correlation with fatigue, which suggests, I guess it suggests all sorts of things. But there was another study around executive functioning, which was around compared neurosarcoidosis patients and people they regard as in research speakers healthy controls, and that showed no difference in executive functioning. So I'm quite interested in that as well, to get some thoughts around that. That you know, that there didn't seem to be that particular thing happening. Obviously, you will definitely get memory problems, certainly, so if there's damage and lesions in the brain, and you will also get memory problems caused by the inflammatory process and sort of flaring. And then the other thing that Desmond mentioned a few times, and I want to just have one slide on it because it's usually ignored, is sexuality and sexual expression. And certainly the literature was talking about decreased libido both in women and men, erectile dysfunction in men, and in terms of body image, means some gynecomastia, so in men as well. And what I wasn't sure about, and maybe again we should think about this with Desmond, is, you know, how permanent is this? Is this treatable? You know, when we think about the kind of pituitary and hypothalamic involvement with neuropsychosis, how permanent can or how treatable are these issues in people? And you know, even if they're not, beyond the kind of physical causes, these things will cause body image concerns for people. They'll cause relational, how we experience our sexual selves with other people, with either intimate partners or when we meet partners for the first time, if we're not in relationships. And that kind of impact on our sense of who we are and identity. Our sexual selves are an important aspect of identity. And in terms of erectile dysfunction, I was kind of interested, even if it is treatable, you know, with a primary sexual dysfunction around neuropsychosis, that you may, even if it is treatable, you may develop a secondary erectile dysfunction, which is the fear that there'll be problems with erectile functioning, and then anticipatory, and then what we call kind of more classic psychological cycle of erectile dysfunction, where people get like a bit like performance anxiety, if you like. So I'm quite interested to hear the people's comments around and experiences around that. Okay, ways of helping. So I'm aware I knew I would go over time, but I do apologise. Some ways of helping. All right. Now look, I've hopefully kind of managed to convey to you, when someone comes to see a person like me, they're bringing all their concerns and all their history with them, not just come for one thing. And really, these are, this all has to be taken into account and has to be brought into any kind of work psychologically with someone. You can't just pull out kind of things in isolation. You have to really understand people's lives and their context and what their concerns are and what they want to understand and what they want to find ways to have help with. Now, this seems like a simple slide, but you know, without family and personal relationships and without building networks of support and communities like you've got the Sarcoidosis UK Society, without this, you know, psychological therapy is a poor kind of compensation, I would say. You know, it's important to have inbuilt relationships and support for people who care about you. That's the most important thing. And to have belong to a wider community of people who understand you in a world that frankly will not understand you very well. And the importance of advocating and working and educating healthcare professionals and the general public about these issues can't be underestimated, and that takes time and a lot of effort. But I think, you know, autoimmune conditions generally have got a higher profile now, and I think it's a great thing. And people are understanding these things a little bit more, but I think there's a lot more work needs to be done, and that's the work that I think you have to do as advocates and political advocates for your health. So when I hone it into the work that I do as a therapist, you know, as a psychologist, you know, one-to-one therapy might really involve looking at the kind of focus around people living with a life with a long-term condition, and all the things that might involve. Now, the rest of these kind of slides are more like self-help, and I wanted to just give this to you to get you to think about ways that you might be able to help. And may be stuff, but these are some of the things that I think are useful. Now, the first two books are mindfulness books, and a lot of you have come across mindfulness. I'm sure it's kind of everywhere now. It's been in vogue for a long time now, but it can be helpful. And I use that as a kind of as a baseline, as a baseline to help go with what I call kind of psychological well-being. I always recommend, when I'm recommending self-help books, that people start with these books first, the kind of Mindfulness for Health or the Finding Peace in a Frantic World books. People have different preferences. So, and then I would kind of think about building meaningful life through what we call acceptance and commitment therapy. And generally, if you go to a clinic or a clinical health psychology clinic, this is the kind of work they'll be doing with you anyway. And acceptance commitment therapy, I think, is a really helpful way to kind of reevaluate and rebuild your life based on that idea of values-based living. And then the third book I would recommend is the Compassionate Mind Workbook, which is really about developing a relationship with yourself and other people. Because I think that takes so many knocks through this process. And I say to people, you know, if you're going to do this, go through this kind of self-help, then go through it in that order. Do the mindfulness books first, then the acceptance and commitments, the happiness trap book, and then go and work through the Compassionate Mind Workbook, and do it slowly. And I usually say to people, you know, work through the 3 books over the period of a year. So you could really get and understand it. Now, beyond that, a book that I'm more recommending, because there's such a lot of trauma when you're having to live with an autoimmune disease, is something like Compassion Focused Therapy for Trauma, the Deborah Lee book. But I would not recommend that before you read the first 3 books, before you work through the first 3 books, because it can be quite it can be quite challenging for people to be in touch with some of the trauma experiences they've had. And I also say to people, there's increasing evidence in autoimmune conditions that therapies like eye movement, desensitization, reprocessing, EMDR, can be very helpful for people, and you would need to go and see a therapist for that. But it can be very useful. And then there's other things, positive sexuality, living with chronic pain and fatigue. There's all these kind of self-help type books. There's a series of books called the Overcoming series, which I really kind of hate the name Overcoming, because we're not really overcoming this stuff. It may be kind of working with or living with. It might be a better idea, a better way to kind of label these or call these books, but they have some helpful aspects to them, I think. But like everything, you know, you may be selective. I think some of the chronic pain work, I think, when you're looking at relapse and remitting conditions, can be difficult, because you have both acute phases of pain as well as chronic pain, and actually some of the techniques for chronic pain don't work, because some of the pain you have is acute, it's not chronic. And same with the fatigue. I think I always put fatigue work with a big health warning, particularly around the idea of graded exercise. I think it's helpful, but it needs to be done at the right time. And people need to understand, I think, that actually it waxes and wanes, and just because you can do one level of exercise one day doesn't mean you can use that as a baseline for another day. I don't think that's right. Okay, and then these kind of final two books, which is Living with the Enemy and Facing the Storm. These are based on acceptance and commitment therapy. Now, you know, people have a real mixed relationship to these books. I think there's baby in the bathwater, but I do think there's some bathwater as well. All right. I think for some people, even just the name Living with the Enemy is really problematic because, you know, well, the enemy is my body. So, you know, the idea that somehow the body is an enemy is not helpful. And I can see that. But I think there is some helpful ways forward in this with these books as well. All right, and I'm aware of the time, but I do want to go through this. I'm sorry I'm hogging all the time, but I'll go through it very quickly. You know what? It's about medical trauma, or what I sometimes call trauma by 1,000 cuts. Now, how do you know you might have it? Well, look, when you're going to consultations, do you have anticipatory worry? Do you ruminate? Do you recall and remember previous very difficult consultations? Do they come to mind? Do you start reliving them? Do you get panic and anxiety feelings about them? Do you get upset or angry when you're remembering them? Do you get anxious or upset during an appointment? Do you become numb? Do you become distracted or passive during appointments? Do you forget what you wanted to say? And are you able to process what's being said? If you've got problems with this, you might have, and if these problems are repeated, you might have some medical trauma. I might have to think about it. You know, the first, most important thing is to recognize it's happening to you. And I think often when people recognize it's happening to them, then actually they can pull themselves out of it. They could calm down, they could bring themselves back to the present moment. And you know, learning some breathing and grounding techniques can help you keep you in the present moment. When you go into your consultations, if you can, bring a trusted person with you, and someone who's sensitive enough to can see when you're in need of extra support. So that person who can tell you when you're speaking too fast, or you're rambling, or you seem to be glazing over. And I think it's really helpful to let whoever you're speaking to, the doctor or the nurse or whoever, let them know how you're feeling and why you're feeling that. And this is, yeah, you may be feeling these things because of very difficult consultations in the past. Also write down your concerns and questions because you might forget them. And if you do need to, it's repeated and it's really intrusive, then think about this as trauma and go and seek help for it. I say to people, your role as the patient, the one role you have in the consultation is to advocate for your health. And if people can, you'll often, and you probably a lot of you do already, organise and be your own case notes manager, organise and bring letters with you. It's very helpful when you've got multiple consultations. If you can, keep a diary of symptoms, and if you can, turn that into a graph, something visual, because that can capture a lot of information for a doctor very visually, very quickly, and then they'll usually appreciate it. And also have some knowledge so you can discuss with the doctor aspects of your condition they might not fully know about. Okay, all good and all well, all well said and done. But also there is a doctor-patient power dynamic. We can't get away from it. You know, the power is everywhere, as Foucault would say. You know, doctors and healthcare professionals, they are there to help you, but they are also gatekeepers to healthcare. Yeah, and that can elicit a lot of fear in people. So fear of being a bad patient or being labelled a bad patient, and it can really render patients unheard and angry and distressed and all kinds of feelings attached to it because they don't want to be seen as a bad patient and upset the doctor. But I think it's helpful to explain your fears to the doctor, and most doctors will respond to that, no matter how busy they are. But I would say at the very end of this, and I'm sorry it's not particularly positive, but they do come in all kinds of shapes and sizes with their own styles and approaches. And if you're repeatedly getting nowhere with a doctor or a healthcare professional, you really should consider a second opinion on that. And maybe it's just not a good fit. Okay, I think that's me finished. Thank you very much. Look, I know there's a whole lot of other stuff I haven't touched on. There's things like stress responses and things, and there's lots of things we could go into. You could probably spend at least half a day and possibly more going through a lot more stuff in more detail. But I hope you've got some sort of flavour of some of the ideas, and I hope some of it resonates with you. I think for today, if some of this can resonate and be one or two things could be of use to you, then I think I've done a good enough job. All right, thank you.